Good afternoon, Professor Han. It's a genuine pleasure to meet you. First, I want to express my deepest appreciation for your remarkable contributions to clinical research, especially your leadership in the Smart Choice 3 study. Your work has not only broadened our understanding of interventional cardiology, but now we have a lot more to study in regards of the antiplatelet strategy in interventional cardiology. Today, I hope to explore your motivations and your challenges that you have encountered and the future directions of this exciting field. I would like to thank you for sharing your time and your expertise with us.
Good afternoon, Professor Kang. I'm very pleased to be here on behalf of the Smart Choice 3 investigators. It's my honor.
Yes, so as I as we all know, this is going to be a interactive interview, which will be uploaded to the JACC Asia Pulse, and the potential audience will be everybody around Asia in who's studying in the cardiology field. So I hope that our interview with you will give a large inspiration to our potential audience. So for the first question, I would like to ask you, what was the main goal of this Smart Choice 3 trial?
Aspirin monotherapy is the standard treatment in patients undergoing PCI who completed a standard duration of the DAPT. However, the evidence supporting the aspirin monotherapy is out of date and not abundant. Therefore, we compared clopidogrel monotherapy with the aspirin monotherapy in patients undergoing PCI who completed standard duration of the DAPT. Our hypothesis was that clopidogrel monotherapy would be superior to aspirin monotherapy in these patients.
Yes. Well, as you said, traditionally aspirin was the only monotherapy that was used, but now we have a lot of other antiplatelet agents, and one of the representative antiplatelet agents is clopidogrel. It's widely used. However, there's not many studies, especially in the chronic phase, how we should use these patients for a patient lifelong. So regarding the Smart Choice trial, a lot of evidence is outdated. It was evidence before the era of PCI. So can you explain how and when the Smart Choice 3 trial was performed?
The Smart Choice 3 trial was an investigator-initiated, multi-center, randomized, open-label trial that was conducted at 20 sites in South Korea. From August 2020 and July 2023, a total of 5,503 patients underwent randomization in a one-to-one fashion. So patients who met the inclusion criteria were randomly assigned to receive the clopidogrel monotherapy or aspirin monotherapy.
Yes, so because this trial was conducted after the year of 2020, I think that this is a very contemporary population that we have. So it's not a population that was treated with DSs that we don't use anymore. It's the DSs that we use very right now. So I think that the findings should be very important for this population. So then, could you explain the major findings and how can we interpret the numbers of the study?
Yeah, the primary endpoint of the Smart Choice 3 trial is the MACE, defined as all-cause death, non-fatal MI, or non-fatal stroke, so-called the hard endpoint. During median follow-up of 2.3 years, MACE rate was significantly lower with the clopidogrel monotherapy compared with aspirin monotherapy. 4.4% versus 6.6%. The benefit of clopidogrel monotherapy was mainly due to reduction in myocardial infarction. The major secondary endpoint was bleeding, but there is no significant difference in major bleeding or just bleeding between the two groups.
Okay. Um, So then it reduced the ischemic risk while the bleeding risk was similar. As you said, the patient population that was included in this study was not all comers. They were quite a specific or high risk, probably, population. So then, what is the implication for these patients that were included in the Smart Choice 3 trial?
Yeah, previously the host exam trial investigated the same topic that was dealt with the Smart Choice trial. So the host exam trial is the first contemporary study to compare clopidogrel monotherapy versus aspirin monotherapy. In that trial, the clopidogrel monotherapy was superior to aspirin monotherapy, as you know well because you are one of the principal investigator of the Hustig's trial. So our results was in line with the Hustig's trial. However, we would like to focus on the patients at high risk for recurrent ischemic events. So we included patients with prior MI, medication-treated MI, or complex coronary arterial lesions. And the Smart Choice 3 trial was the first one that demonstrated the reduction of hard end points with the clopidogrel monotherapy.
Yes, so then if we combine this with the host exam trial, now there are two large-scale clinical trials. Of course, the patient population were slightly different. However, we have two clinical trials which have shown the superiority of clopidogrel over aspirin. Then, what about a study that was performed almost 30 years, the Capri trial? Would there be any difference between that trial and the Smart Choice 3 trial?
Yeah, there are a substantial difference between the CAFRI trial and the host exam and the Smart Choice trial. As you mentioned, the CAFRI trial was conducted almost 3 decades ago. At that time, the patients did not receive a systematic DAPT, and the dose of aspirin was 300 milligrams. So the patients who were enrolled in the Capri trial was substantially different. Those enrolled in the Smart Choice trial as well as the host exam trial.
Yes. So, well, one more interesting thing is that despite that we have a different patient population in a different era, both, well, all three, the Capri trial, the host exam trial, the Smart Choice 3, all showed superiority of clopidogrel over aspirin. So now probably we can have some more confidence in recommending clopidogrel as the default, probably monotherapy agent that we have. As far as I know, in the SMART 3 trial, correct me if I'm wrong, clopidogrel showed survival benefit. So even in this is 2.3-year follow period. So how can we interpret this result?
Actually, we did not find a significant reduction in all-cause death nor cardiac death. The benefit of clopidogrel was mainly due to reduction in myocardial infarction. There was some tendency favoring clopidogrel monotherapy with regard to all-cause mortality, but the statistical significance was not achieved, and our study did not have adequate power for mortality, unfortunately.
Okay, thank you for correcting me. Then, as the host exam trial, they did a extended follow-up. Is there any kind of plan for doing an extended follow-up for the Smart Choice 3 trial too?
Yeah, we have a plan to do the same extended follow-up up to 5 years.
Okay, thank you. So, another thing is that when we want to recommend clopidogrel as the default monotherapy agent, one thing that's always in our mind is that there was a concept that was quite important, the clopidogrel hyporesponsiveness. And this was known to have a higher prevalence in Asians, well, especially in East Asians, because we are treating East Asian population. Why was clopidogrel still superior compared to aspirin in this population who has a higher risk of clopidogrel hyporesponsiveness?
Yeah, as you mentioned, the prevalence of patients with poor or intermediate metabolism to clopidogrel was higher in South Korea and East Asian compared with the Western population. However, in Korean multicenter studies, the impact of genotype for clopidogrel metabolism, such as CYP2C19, was diminished beyond 1 year after PCI. So the impact of genotype was prominent in patients ACS with ACS within 1 year because we exclusively enrolled patients who completed standard duration of DAPT. That means 6 months for CCS and 1 year for AMI. So in our trial, the impact of genotype for clopidogrel metabolism seems not too substantial. And that's why clopidogrel was superior to aspirin in these patients.
Yes, so to summarize your talk was that because this was a stable CAD population, probably the impact of clopidogrel responsiveness may not be that large compared to the acute phase. So again, because we have a large population of patients with stable CAD who have a long life expectancy, in this patient population, probably we could be we could use clopidogrel more safely without concerning the hyporesponsiveness. So now we have, as I said, we have two contemporary randomized clinical trial. Regarding the guideline recommendations, there are a lot of strict ways that we can upgrade the level of evidence. So regarding the level of evidence, how high do you think that clopidogrel usage can be ranked regarding the previous trials that we have right now?
The most recent Europe and American guideline have already recommended clopidogrel monotherapy as well as aspirin monotherapy as class 1 in patients who completed standard duration AMI, duration of DAPT. However, in real-world practice, aspirin monotherapy was much more prevailing. So after the host exam and smart choice trial, I hope the clinical practice pattern will be changed. And I'm not sure that clopidogrel monotherapy should be default strategy in all patients. However, based on the results of the smart choice trial, at least in patients with high risk for recurrent ischemic events, such as prior MI, medication-treated diabetes, or complex PCI, for those patients, we can prefer a clopidogrel monotherapy to aspirin monotherapy.
Yes, thank you. So ultimately, we have to do individualized medicine, but still we have to have a standard of some way, and probably in those patients that were included in the Smart Choice 3 trial, clopidogrel monotherapy could be a very good option. So finally, I know that you have a lot of publications in the field of antiplatelet agents. In some time, we thought that there should be no more antiplatelet agent studies because there were too many, but still we have a lot of questions to be answered in this field. So then this might be a slightly difficult question, but could you provide your future perspectives of regarding the field of antiplatelet therapy in coronary artery disease?
So one of the most important population is patients with high bleeding risk. Patients with high bleeding risk have high risk for bleeding as well as ischemic events. So abbreviated antiplatelet strategy is not adequate strategy for all patients with high bleeding risk. So perhaps the genotype guided strategy may be an option for patients with high bleeding risk, especially within 1 year. And the second problem is patients who have the intermediate lesion. The patients do not undergo PCI, but they have some atherosclerotic burden. In primary prevention trial, aspirin failed to demonstrate any benefit for these patients, but clopidogrel is one option. And we know the host prevention led by Professor H.S. Kim and your group that will answer us this very important message issue.
Yes, so well, as you said, we still have a lot to study. We still need to have clear evidence for the patients that meet our clinic right now. As you said, the patient populations are not PCI populations. They're coronary artery disease populations, which are very complex. So for the past about 15 minutes, we had a very in-depth interview with Dr. Joo-Yong Hahn, and I hope that the audience could have a inspiration of the principal investigator of the SMART 3 trial. And for lastly, I would like to thank you for your time and your explanation for the slightly difficult questions that I had. And I hope we can meet in the future anywhere around the world. Thank you for your time.
Thank you, Professor Kang.